Hello, my name is Roxanne Chabot from RBC Consultants. Welcome to another International Dermatology Education Foundation Educational Series webinar. Today we're going to be talking about mild to moderate atopic dermatitis, burden of disease, and topical pathway. Our moderator today is Dr. Leon Kircik. Dr. Kircik is president of the International Dermatology Education Foundation, clinical professor of dermatology at the Icahn School of Medicine at Mount Sinai in New York, Indiana University Medical Center in Indianapolis, and medical director of physician skincare, DermResearch, and skin sciences. Our speaker today is Dr. Linda Stein-Gold, who is director, researcher, head of the Division of Dermatology at Henry Ford Health System, and vice president of the American Academy of Dermatology. And Dr. Stein-Gold is in Detroit, Michigan. We'd like to thank our supporter, Incyte Dermatology, for making this educational event possible. Before we begin, a couple of logistic tips. If you're having issues hearing the webinar, you can listen to the presentation using your telephone. Just select phone call in the audio pane and the dial-in information will be displayed. If you're having technical issues or if you would like to submit a question to our faculty, please submit your questions in the question chat pane on the right-hand side of your screen. Within 1 to 2 days of the webinar, a survey link will be emailed to you, and we greatly appreciate it if you could fill it in and send it back to us. Again, if you want to submit a question to our faculty, you can submit your question in the question chat pane on the right-hand side of your screen, and I wrote a little note there so you could see where you need to type in your question. So without further ado, I will pass the floor virtually to Dr. Leon Kircik.
Thank you, Roxanne, and welcome everyone. Good afternoon. Greetings from Long Island, New York. So I'm very happy today. We have a little bit different timing. We are running an early program today, and hopefully all our East Coast and West Coast viewers will be on, as well as the middle of the country. So International Dermatology Education Foundation is a nonprofit organization, and our principal mission is to raise awareness and improve dermatology care all over the world through education, especially in underserved areas. And since COVID, we have done several webinars, both nationally and internationally, both in the US, Canada, as well as Europe, Southeast Asia, and South America. Some of our previous programs are here, as we can see on the next slide, please. And we have several programs supported by different supporters. And today we are very lucky to have Dr. Linda Stein-Gold, and she's gonna tell us all about atopic dermatitis and ruxolitinib. So Linda, take it over. Welcome.
Thanks so much, Leon, and what a treat it is to be here with everybody today. I do have to say I finished my vice president role, and I'm now the immediate past vice president, and that was a wonderful time. So today I'm really excited to be talking about ruxolitinib cream. This has been FDA approved for the treatment of mild to moderate atopic dermatitis. And this cream, which is a topical agent, will help to relieve the burden of atopic dermatitis in our mild to moderate patients. I'd like to thank Incyte for supporting this presentation today. This is a promotional program, so we do have to stay on label, but there is a wealth of information to go through today. Looking first at the indication and usage, this is FDA approved for the topical, short-term, and non-continuous chronic treatment of patients with mild to moderate atopic dermatitis who are non-immunocompromised, and those patients can be age 12 and up. And it's for those patients whose disease is not adequately controlled with topical prescription therapies or when it is not advisable to use them. Good news is that it's also FDA approved for the topical treatment of non-segmental vitiligo in adult and pediatric patients age 12 and up. When we talk about limitations of use, Opzelura is not recommended for use in combination with biologics, other JAK inhibitors, or potent immunosuppressants. Now, we have some important safety information to go through, and it's going to be gone through in much more detail later on in the presentation. I'm going to begin with just covering the boxed warning. There is an important safety call out for serious infections that have led to hospitalization or death, a higher rate of all-cause mortality, lymphomas and other malignancies, higher rates of MACE events, including cardiovascular death, MIs, and stroke, thromboses, including DVT, PE, and arterial diseases. And these risks have been seen with JAK inhibitors used for the treatment of inflammatory skin diseases. So before we get started with all the data, we're going to basically talk a little bit about atopic dermatitis. How does it present? How do we make the diagnosis? We'll look at the patient journey, and then we'll talk a little bit more about how to get this disease under control. This is one of the most common skin diseases that we see in the United States. We know it affects about 30 million Americans, and we see it in approximately 13% of children and about 7% of adults. And it's interesting to note that this can occur actually as an adult. In fact, about 25% of our adult patients who have atopic dermatitis develop the disease as an adult. And when we look at our basket of atopic dermatitis patients, it turns out that the majority of these patients actually do have mild or moderate disease. Now, atopic dermatitis is a heterogeneous disease, and it classically presents with some ill-defined plaques, and they tend to thicken over time, especially as the patient scratches them. In adolescents and adults, it tends to favor the flexural areas and also the neck and around the eyes and the hands. And we can see acute lesions, which can be papular vesicles, or chronic lesions that can be lichenified in exactly the same patient. So it's a good idea to have that patient, especially on their first visit, to undress and really get a good idea of how much of their body surface area is truly involved, because sometimes the patients really don't even know for themselves. It's also important in our patients with skin of color that the erythema can be very difficult to assess. Sometimes you have to look at normal skin and compare it to involved skin in order to appreciate how erythematous it really is. And these patients with skin of color often have post-inflammatory changes, including hyper or hypopigmentation. Now, the patient journey in any patient with atopic dermatitis can be a roller coaster ride. It has exacerbations and remissions, and the itch is really the most troublesome component of the disease. And it really can consume the patient's life. It affects their overall quality of life. It affects their sleep. It can basically consume pretty much everything. It makes them very irritable. And it's not only the patient, but actually the entire family unit that can suffer when one member of the family is suffering from atopic dermatitis. Now, this is a cross-sectional study that was conducted that asked patients to describe their most burdensome symptoms. And it turns out that 54% of patients described the itching and scratching as the most burdensome, and about 20% said this was the second most burdensome. So overall, we see that about 3/4 of the patients really found itching to be quite burdensome overall. And then we see that excessive dryness and scaling. So it really turns out it's not only the physical rash, but also the itch that really consumes our patients. Now, this was a study that asked patients and physicians, how well are we getting our atopic dermatitis patients under control? And we were in pretty good agreement. And unfortunately, the agreement was we're not doing the best job in getting these patients under control. Now, this study was conducted in 2014 prior to the approval of biologic agents or oral JAK inhibitors for atopic dermatitis. But we see for those patients who have severe disease, about 9 out of 10 almost are not controlled the way we need them to be. But even when we look at those patients with mild to moderate disease, it turns out we're not doing our best job in getting these patients under control successfully. Now, there's really a stepwise approach to the treatment and management of atopic dermatitis, and it always starts with proper skin care. We understand that bathing is actually good for patients, especially if they utilize a soak and seal method. where they have a bath or a shower where they keep the water temperature down. They use a gentle cleanser. When they get out of the bath or shower, they use a good heavy moisturizer, and we call this soak and seal to seal in that moisture. We then turn to topical therapy for those patients, especially with more mild to moderate disease. Topical corticosteroids are really the cornerstone of treatment, and then we turn to topical calcineurin inhibitors and PDE4 inhibitors for especially those sensitive areas. Now, for the patients who were not getting under control with those traditional topical therapies, this is where Opzelura or topical ruxolitinib comes into play. And again, this is FDA approved for those mild to moderate patients age 12 and up who don't get under control with our traditional topicals. And then for those patients who have more moderate to severe disease, we have biologic and oral JAK inhibitors that we can turn to with really very nice effects for this patient population. So when we think about treatment considerations, it's clear that we need more options. We need options that can simplify the treatment regimen. We want to allow patients to use one treatment on multiple body surface areas. We want to be able to treat the thick areas as well as the sensitive areas. We'd like to have a treatment that doesn't discolor those patients who have skin of color, where we know especially potent topical steroids can lighten that skin. We'd prefer to have something that doesn't cause atrophy. So overall, what we need is something that's effective, something that's well tolerated, and a treatment that can simplify the treatment regimen. So now we'll switch gears and take a look at Opzelura or ruxolitinib. Again, this has been FDA approved for those patients age 12 and up who have mild to moderate atopic dermatitis. So let's take a look at the pathophysiology of atopic dermatitis. And this is kind of a complicated skin condition. The more we learn about the disease, the more complicated we understand that it is. We know that there are three main factors in the pathogenesis. We have a defective skin barrier, we have an upregulation of type 2 cytokines, and we have genetic abnormalities, including an abnormality in filaggrin. So first, what we know is when we talk about the skin barrier, it's defective. It has a hard time keeping the outside world out and the inside world in. We see an influx of allergens and antigens. We see an efflux of water with an increase in transepidermal water loss. With this disruption of the keratinocytes, we see a release of alarmins like IL-33 and TSLP. These recruit inflammatory cells, including those Th2 type cell mediated cells. We see an increase in those Th2 type cytokines. We see that there's a predominantly Th2 response, and we see the upregulation of IL-4, IL-13, IL-31, and TSLP. We see this causes activation of the itch, including direct response on the sensory neurons from TSLP and IL-33, and an indirect effect with IL-4 and IL-13, increasing that environment, causing a hyper response to those neurons, to the stimulation of the itch. And what's interesting is we see that these cytokines actually have an effect on the skin barrier. We know we have a genetic abnormality of filaggrin, but we can also have an induced abnormality of filaggrin. We know that both IL-4 and IL-13 can downregulate filaggrin, further causing an impairment in the skin barrier. So we see an upregulation of inflammatory cells. We see a heightened immune response that causes even more scratching. With that scratching causes even more inflammation and more damage to the skin barrier, and we have this vicious itch scratch cycle that perpetuates this entire response. Now, Opzelura is a topical JAK inhibitor. It's the first and only topical JAK inhibitor, and it's been FDA approved for the treatment of mild to moderate atopic dermatitis. And when we look at those key cytokines that are upregulated in atopic dermatitis, including IL-4, IL-13, IL-31, and TSLP, the way these drugs transmit their signal is through something called the JAK-STAT pathway. The JAK-STAT pathway is a pathway that translates extracellular signals excuse me, including IL-4, IL-13, IL-31, and TSLP, and it translates that into an intracellular response. So what happens is these cytokines float around and they find a receptor that they're attracted to on the surface of the cell. They're carrying a message that they want to create more inflammation or a pro-inflammatory response. So when they bind to that JAK-STAT pathway, they bind to two cytokines that come together or dimerize, and they transmit that signal through this receptor complex. And when those cells come together and dimerize, they receive the information, they become phosphorylated, and the STATs, or the signal transducers and activators of transcription, come over there and they bind to that, those phosphorylated JAKs. They pick up the signal, and then they're on a mission. They pick up that signal and they go off to the nucleus and oversee the production of cytokines. And what's interesting is we know that these pro-inflammatory cytokines bind through this JAK pairing, and it often involves the JAKs 1 and 2. So why is it important to use a topical medication? Why wouldn't we care about a topical medication when we're talking about especially mild to moderate atopic dermatitis? When we think about the pathogenesis of the disease, we know we see hyperplasia, we see inflammation in the skin. We know that we see an increase in CD3 cells, which are a sign of T cell activation. We see an increase in CD11C cells, which are a sign of dendritic cells. And a lot of this activity is going on in the skin. If you think about it, when you apply medication directly to the skin, we have high levels of concentrated drug directly on the skin, and we can minimize the drug that's absorbed into the systemic circulation where we don't necessarily need it. So it makes sense to maximize the effect of putting the drug exactly where the site of action is. So now let's take a look at the Opzelura or ruxolitinib clinical trial program. And I was fortunate, I'm a medical dermatologist. I run the clinical trials at Henry Ford Health, and I've been involved in the Opzelura clinical trial program. So I can speak from some of my personal experience. The first thing I want to make note of is when we look at the clinical trial program, we see that there is just a wealth of clinical trials that were performed to support the drug going before the FDA. We had phase 1 studies where we have a maximum use study, where we put a lot of medication on these adolescents and adults and see what happens in the systemic circulation. We had a phase 2 study, and what was interesting about the phase 2 study is we had an active control. We used triamcinolone cream in the phase 2 study, looking to see how does this drug compare to a mid-potency steroid. And then we had 2 large phase 3 clinical trials where these were double-blind, vehicle-controlled, randomized, multinational studies where patients aged 12 and up were treated with 2 concentrations of ruxolitinib cream, the 1.5%, which is Opzelura, and the 0.75. These patients were treated every day, twice a day, for 8 weeks. But then the good news is we have a long-term safety study that came after that, where patients were treated on and off drug as needed to look to see what happens in terms of long-term safety, but also what happens in terms of long-term efficacy. So let's take a look at the results from the 2 phase 3 clinical trials studied in both adults and pediatric patients, again, with mild to moderate disease. Now, what's important is when we're looking at these phase 3 clinical trials, there's 2 studies with different investigators, different patients, different areas, and we're looking to make sure that both of these studies are statistically superior to the vehicle in showing efficacy as well as safety of the Opzelura. So how was the study, how were they done? Basically, we enrolled patients who were aged 12 and up. They had to have atopic dermatitis for at least 2 years. They could have mild or moderate disease. And we treated between 3 and 20% body surface area, but we didn't treat the scalp. The main reason we didn't treat the scalp was because it's a cream formulation. And for every 2 patients who are on the 0.75%, the Oxalora. One patient was on the vehicle cream. So it was a 2 to 2 to 1. Again, it's a cream formulation that was used BID. And we treated these patients every day for 8 weeks. And then we had a number of other assessments that we were looking at as well. And we'll go through those. So the primary endpoint, and this is important, this is the investigator's global assessment treatment success of getting patients to clear or almost clear with at least a 2-grade improvement. And I'm going to explain what that means. When we look at the investigator's global assessment, that means we look at the patient really at arm's length and we say, overall, looking at your entire body, how do we assess your disease? And remember, they all came in with mild or moderate disease. We're asking these patients to use monotherapy, use the medication twice a day with nothing else, no other steroids, nothing else. And they have to get all the way to clear, almost clear. And that's the whole body has to be clear, almost clear. Now, for those patients who came in with mild disease, they had to get completely clear because they needed to have a 2-point improvement. So that means if you came in with mild disease and you had a little bit of pink skin remaining, you're not a treatment success. It's a very high bar. It can be very difficult to get those patients to completely clear skin. So a high bar. And then we also looked at a number of key secondary endpoints. Itch is very important for these patients. And we assess the itch on a scale from 0, meaning no itch at all the way up to 10. And we're looking to see how many patients had at least a 4-point reduction in their very worst itch. And that can be kind of a challenge to get these patients who've been scratching for the majority of their lives down to a 4-point improvement. And we also looked at an EASI 75 or a 75% improvement in their overall EASI score. And the EASI score is kind of a holistic measurement that looks at different parameters of the plaques of their disease, as well as different body sites, and gives kind of a holistic grade on how they're doing. So basically, how did these patients do? Basically, what we see is that a lot of these patients, about 20%, were adolescents between the ages of 2 and 17. We had a nice distribution by race. We see that we also had about 23% of the patients were Black or African American, about 4% Asian. 75% of the patients had moderate disease, 25% had mild disease, and the mean body surface area was about 10%, and their itch score was about a 5. So what we see is, because we looked at patients who had between 3 and 20% body surface area and the mean was 10%, a lot of these patients actually were potentially systemic candidates, especially those patients who had 15, 16, 17, 20% body surface area. It's also important to note that 39% of the patients had facial lesions at baseline. So again, we're using a non-steroidal topical agent, topical JAK inhibitor, for these patients, and they were allowed to use the medication on their face, even on their eyelids, on their hands, on their legs, on their body. They just didn't use it on their scalp. So the question is, how many patients were a treatment success over the course of 8 weeks? And as somebody who runs clinical trials, the first thing I do is I look at the 2 studies. And what I find is they almost look like exact mirror images of each other. And when we see very reproducible data, it tells us that this is very believable data. You know, it's kind of remarkable that we saw the same thing with different investigators, different patients. What I see is at the first assessment, which was week 2, we already have a nice separation of the active drug from the vehicle, and we see continued improvement and continued separation over the course of those 8 weeks. More than 50% of patients achieved that 2-grade improvement, getting the patients to clear or almost clear. Or could have gotten a 3-grade improvement if they went from moderate all the way to clear. Now here's a patient at baseline with moderate disease. You can tell from this picture that this patient's scratching. You almost don't have to ask because we see the excoriations at baseline. Here we are at week 1 with a nice improvement. I'm sorry, at week 2 with a nice improvement. and continued improvement over the course of 8 weeks. So we can see the patient journey with a really nice clinical response over the 8 weeks, but also kicking in fairly early by week 2. Another patient, here they are with moderate disease. You don't have to ask again if it's itchy. We can see the excoriations, and we wonder, are they going to see anything early on? And by week 2, we already see the patient getting to almost clear of their disease. So it's by definition, even by week 2, they're a clinical success because they got to a clear or almost clear with that 2-grade improvement and continuing on through week 8. So here again, this is a non-steroidal topical. They can't use any steroids or anything else. They have to use this drug as monotherapy over the course of the 8 weeks. What about itch? And itch, as I mentioned earlier, this is the #1 thing that our atopic dermatitis patients are concerned about, even with those patients who have mild or moderate disease. Remember, they came in with an itch score that was about a 5 out of 10, and we're looking to see how many of them had at least a 4-point reduction. So a 4-point reduction coming in as a 5 means that a lot of these patients are getting all the way down to minimal itch or even no itch. Again, at week 2, we see a nice separation of the active drug compared to the vehicle. The 2 studies are almost mirror images of each other, very nice reproducible data. And we see that over 50% of patients are getting that 4-point reduction of itch at the end of 8 weeks. But it's also important to note that as early as day 2, there was a statistically significant difference in early response compared with the active drug as compared to the vehicle. Over 10% of patients on active drug saw a 4-point reduction compared to about 3% on the vehicle. Now, this is a really important slide because this looks at how patients did every single day. And patients actually had a diary, and they could put in their worst itch over the course of 24 hours. And what we see that very steep reduction of the purple line, and those are the patients who are on Opzelura. And what we find was within the first few days, actually as early as day 1, patients reported a change in their very worst itch score. So you can tell patients with pretty much confidence that definitely over the first week, and for some patients within the first day or 2, they might see a reduction in their worst itch. Now, how many patients had an itch score that got down to 0 or 1, which means basically no itch at all? And here we're looking day by day for the first week or so. And what we're finding is that there is a separation from the vehicle. We start to see separation as early as day 1, and that continues over the course of the 7 days, with 36% of patients within the first week saying that they don't really itch very much at all. They have a 0 or a 1, which means negligible itch. So that's really pretty dramatic as compared with just the vehicle alone. What about an easy 75? What about a 75% improvement in their overall severity of disease? And what we find was, again, very reproducible data. We see well over 60% of patients achieving that 75% improvement in their EASY score by week 8. So continued improvement. We see separation at week 2 and continued improvement over the course of the 8 weeks, and a pretty dramatic delta or difference between the active drug and the vehicle over time. What about an EASY 90? And an EASY 90 is basically a 90% improvement in your overall assessment of disease. An EASY 90, if somebody gets an EASY 90, if they had, for instance, moderate disease, that means that you can potentially put on a bathing suit and you don't have to wear a cover-up. You're not bleeding through your clothing. You can walk out with a halter top on, or a guy can walk out with shorts and no top, go out in public, and nobody's going to look at you and wonder what's wrong with your skin. And we see that we had an EASY 90, nice separation as early as week 2, and we see again continued improvement over week 8 with a good percentage of patients in the 81, 44% achieving that 90% improvement. So here we're looking at the mean change from baseline and EASI score. And the reason this is important is because when we look at an EASI 50, an EASI 90, these are black and white numbers. If you had an EASI 89, you didn't get to an EASI 90. So you're counted as a no, an absolute no. So sometimes it's nice to see what was the mean change in EASI score. And here we see, notice within the first 2 weeks, you can say that half or more of the people saw half of their atopic dermatitis go away within the first 2 weeks. Their average change in EASI was 56% in the first study and almost 50% in the second study. And we see really nice improvement in the first study, 77% mean change in EASI score at the end of 8 weeks. So you can tell patients over time, on average, patients saw an improvement in their eczema. On average, about half of it went away within 2 weeks, and about 3/4 of it went away by week 8. Okay, so what about the side effects? And side effects are important, especially we're talking about a topical JAK inhibitor. Remember that this drug is used for only up to 20% body surface area. And we see the most common adverse events that were reported in the patients on Opzelura or nasopharyngitis, bronchitis, ear infection, increased EOs, urticaria, diarrhea, folliculitis. You know, these are just now in 1%. What's also very important is to note when we talk about non-steroidal topical agents, we do worry about stinging and burning. And I want you to note that there was a low rate of injection site reactions such as burning. In fact, the Opzelura was lower than vehicle, and there was no burning, no itching in the Opzelura group. And when we look at those patients who discontinued due to an adverse event, it was below 2%. In fact, below 1% in one of the studies. So this drug was well tolerated and very well tolerated in terms of local reactions. Now, as I mentioned, this drug did have a long-term extension period. The good news is patients who continued the first 8 weeks were allowed to go into the long-term extension study. This is what's called an open label study. An open label means now everybody got the drug. So before, they were either on active drug or on vehicle. In the long-term study, everybody gets to be on open drug. And by its nature, this is a safety study, but we also collected data on efficacy as well. But basically what happened was after the phase 3 clinical trial at week 8, patients had the option to treat their lesions 20% or low, and they treated their lesions every day, twice a day. If they got their lesion to completely clear, they treated for another 3 days and then they could stop. The beauty of this was patients were in control of their own destiny. If one lesion cleared up on their arm, but they still had a persistent on their leg, they were allowed to stop treating the arm and continue treating the leg. And if they got a new lesion, they could go ahead and start treating that. So the truth is there were some patients who were on drug every day over the course of the 52 weeks. But generally, they treated on and off as needed after they got those patients themselves to clear. So they really were aiming for clear, and then they could stop the drug to any lesions that had cleared completely. It's a little bit different design. It's almost more like a real life design. And what we found was when patients have the opportunity to use the drug as needed and allow themselves to get to clear skin, we see that the majority of patients get to clear or almost clear and remain clear or almost clear, about 2/3 of them over the course of 52 weeks. We don't see any tachyphylaxis. We see a nice, even, straight line over the course of the 52 weeks. And again, these patients were allowed to use the medication as needed. When we look at the BSA, remember at baseline, the BSA was around 10. As they entered into the long-term study, those patients in purple who were on active drug, their BSA was down to just above 2. Those patients on vehicle still had a larger body surface area of involvement. And we see that the BSA decreased nicely over the course of the year. Again, going on and off drug, we see that they ended up with less than 2% body surface area over the course of the year. Now, remember, as I said, the long-term study is a safety study. And the question is, were there any new safety signals that developed over the course of 52 weeks where patients went on and off drug as needed? The bottom line was there were no new safety signals that were identified. Very consistent with what we saw with the phase 3 clinical trials. But again, this is for short-term and non-continuous chronic use in mild to moderate patients with atopic dermatitis. Now, what about those AEs of special interest that we call out in the PI and that we call out, especially in those patients who are taking systemic JAK inhibitors, looking at serious infection? And we're looking at the rate per 100 patient years. And we do this because that way we can compare different time periods. For instance, with the vehicle, those patients were only on the drug for 8 weeks. On the Opzelura, they could treat for up to 52 weeks. So we're looking per 100 patient years. And we see basically that the incidence rates of these AEs of special interest are not significantly different than what we saw with the vehicle. We saw serious infections about 0.2, the vehicle 0, herpes zoster 1.1. We see non-melanoma skin cancer 0.4. Other malignancies actually higher in the vehicle group. Stroke 0.2%, and then PE and DVT 0.2 in the Opzelura group and 0 in the vehicle group. Okay, so how is this drug given? This is a drug that's applied twice a day. It should not be used on areas greater than 20% body surface area, and you shouldn't use more than 20 grams per week. It can be used on any topical area. We want to use it on just regular skin, not in orifices. But it can also be used on sensitive areas. So it definitely helps to simplify the treatment regimen. It is a non-greasy, steroid-free formulation. It's applied directly to mild to moderate disease. And you should stop treating it after the signs of atopic dermatitis resolve. If it doesn't improve within 8 weeks, you should tell patients to have their area re-examined to make sure we have the diagnosis. So now let's go through some of the important safety information. Again, we did talk about serious infections. Patients treated with oral JAK inhibitors for inflammatory skin disease are at risk for serious infections that may lead to hospitalization or death, including active TB, fungal infections, bacterial, viral infections, including zoster. We want to avoid Opzelura in patients who have active or serious infections, including localized infections. If a patient were to develop a serious infection, we want to hold the medication until it's controlled and consider the risks and benefits before initiating Opzelura in patients who have chronic or recurrent infections, and monitor those patients for infections while on the drug. In terms of mortality, there was a post-marketing safety study that was conducted with rheumatoid arthritis utilizing another oral JAK inhibitor. This was compared to a TNF inhibitor. This was a study in patients with rheumatoid arthritis, patients 50 and over who had at least one cardiovascular risk factor. In this particular study, we did see increased risk of all-cause mortality, including sudden death, with the JAK inhibitor. Malignancies were reported in patients treated with Opzelura. Lymphoma and other malignancies have been reported in patients receiving JAK inhibitors to treat inflammatory skin disease. And in that same study, we did see an increase in malignancy in patients on the oral JAK inhibitor as compared to the TNF inhibitor. And it's important to note that smokers are definitely at increased risk. Major adverse cardiovascular events in that same study in rheumatoid arthritis, we did see an increased risk of MACE events, when compared to TNF inhibitors. Again, this is more significant in patients who are current fast smokers. Thromboses, thromboembolic events, have been observed in Opzelura. Thromboses, including PE and DVT and arterial thrombosis, have been reported. Again, going back to that same study, we did see an increased risk in the JAK inhibitor as compared to the TNF inhibitor. Avoid Opzelura in patients who are at increased risk to develop a clot. Thrombocytopenia, anemia, and neutropenia were reported in the clinical trials. You want to consider the risks and benefits before initiating Opzelura. There is no blood monitoring that is in the package label, but if you feel that it's indicated based on a particular patient's history, then it's a good idea to do that. Lipids, treatment with oral ruxolitinib has been associated with an increase in lipid parameters. Adverse reactions, we talked about those in more than 1%, including nasopharyngitis, diarrhea, bronchitis, and others listed here. This drug has not been studied in patients who are pregnant, and there is a pregnant registry that's listed here. It also has not been studied in patients who are breastfeeding, so it's really recommended not to breastfeed when you're on Opzelura and to wait about 4 weeks after the last dose. Okay, so what did we learn today? Opzelura is the first topical JAK inhibitor that's FDA approved for mild to moderate pediatric and adult patients 12 and up. We saw that it blocks that JAK-STAT pathway that's critical for the transmission of the pro-inflammatory signal that comes from the key cytokines, including IL-4, 13, IL-31, and TSLP. We saw it did succeed in getting about 50% of patients were almost clear by week 8, and we saw about 25% of them actually got clear, almost clear by week 2. We saw a nice reduction in the worst itch in more than 50% of patients by week 8. We talked about the adverse reactions. This is not a steroid. It is appropriate to use on sensitive areas as well as other areas. It simplifies the treatment regimen. So we're going to take a look at a few profiles, and there are a number of types of patients that might be appropriate for use of Opzelura. We'll start by talking about Isabel. She's somebody, she's 38, and has a lot of itching, and a lot of these people might have mild disease, but they're so itchy. And she's had chronic itch for a good amount of time. She's tried multiple topicals, including topical corticosteroids. She has about 8% body surface area. It's gotten a little bit more. When we look at her hands and her arms, we see the erythema, the excoriations, her ankles, persistent pruritus, constant scratching. This is a patient who has tried topical steroids, not doing well, and really is looking for something that gets the itch under control. We saw with the Opzelura data that within the first few days, you can see a reduction of itch. We can't guarantee it for everybody, but there are definitely patients that do see the medication kicking in within that first week and actually kind of making the itch something that's much more tolerable. And then we'll take a look at another patient case. This is a patient who's reluctant to use systemic medications. This is Henry. He's a 32-year-old man. He has 18% body surface area. And remember, with Opzelura, we studied patients who had up to 20% disease. So he would be a patient that could have been considered for more moderate disease, up to 18%. And again, there's kind of that crossover, patients who potentially could either use a topical or maybe an oral because they have enough disease. But we saw he's somebody who's failed topical calcineurin inhibitors, didn't do well with topical steroids, talked about using a biologic drug, but just doesn't want to go there at this point. And the question is there something else that he can do? He has a lot of itching, has difficulty falling asleep. And Opzelura is a medication that was studied in this patient population, moderate disease, up to 18%. We did have patients that fit nicely, and this is definitely something that you could look at for this particular patient. Let's scroll through here for a minute. Basically, We know that there has been a lot of activity trying to make sure that patients have access to their medications. Incyte has spent a lot of time and energy making sure that they have a patient assistant program in place, and they have patient assistant cards and programs. So, you know, it's make sure that you document well and advise the patient on the assistant programs for elderly. And that concludes my formal part of the program. And Leon, I think I'm going to turn it back over to you.
Thank you so much, Linda. That was very informative. I appreciate it. And we have a bunch of questions, but before I go there, the last couple of minutes, the connection was not the best, and maybe I misheard the maximum use per week. I thought you might have said 20. Is it 60?
No, I said that the BSA was 20.
Okay, so the amount is 60 grams?
If we can go back up, here we have.
I believe the amount is 60 grams.
Not to exceed per week.
Right.
Okay, do we have some questions?
All right, so we do have questions. One of them is really a very interesting clinical question. How realistic is it to use this medication as monotherapy?
Yeah, you know, that's always an interesting question, because you know that we have clinical trials that mandate we use these medications as monotherapy, because we have to make sure that the drug itself kind of holds its weight and does contribute to getting these patients to clear, almost clear. And, you know, people would ask, this is a non-steroidal topical, can you actually use it as monotherapy? And I'll tell you, I did do the clinical trials. We did use it as monotherapy. Most of my patients had moderate disease, and they were able to get control and keep control over time. So the answer is yes, I do think it's realistic. You know, we're given a armamentarium of treatment options for our atopic dermatitis patients, but this is a drug that I do believe it's realistic to try as monotherapy.
Yeah, and it makes life much easier for our patients, one prescription, right? So you don't have to use many different things. The other thing you mentioned on it, but probably for those of us who don't do clinical trials, it might be nice if you give a little bit more detail. Why is it difficult for the mild patients, since they are mild, to reach to the clinical endpoint, primary endpoint?
Yeah, I agree with you, Leon. That gets a little bit confusing, because you'd say, well, they're mild. How hard is it to clear them up? And unfortunately, when we're doing clinical trials, we have this bar that's so high. The FDA is asking for these predefined definitions of what a treatment success is. And the patients who meet treatment success in the clinical trials aren't all of the patients who are happy in the study. So we ask patients to get all the way to clear, almost clear, but we also say you have to have a 2-grade improvement. So what that means is, if we say clear, almost clear, mild, moderate, and severe, so clear, almost clear, mild, moderate, and severe, if you start with mild or moderate, you have to go 2 grades. So that means if you have mild disease, almost clear, although the patient might be delighted and be your best friend, they are not a treatment success. And to be completely clear means completely clear. Your whole body has to be completely clear. So if you were like scratchy and red and flaky and irritated, and then you got it all smoothed down and it was just pink skin, that's an almost clear. So although the patient might be delighted, it's not a treatment success.
Right, right. Another question I have, and in the long-term extension study, did they look at the EASI score or the body surface area, or was it only IGA?
They did look at the body surface area as well, and we saw that, you know, they came in with a lot of body surface area at the baseline, about 10%. And we saw that after 8 weeks, if they used the drug, they got down really very nicely, around 2% or less. And then as they continue to use the medication, we just saw a nice improvement over time in the BSA. And you're studying these patients over the course of a year. So sometimes, it might they have seasonal allergies and they played outside in the grass and now they're scratchy. So, it's natural for people to have a little bit of an ebb and flow to their disease. And we're watching you over the entire year, but still we maintained a nice improvement in these patients over the course of the year. Again, it's not, we're looking always safety first, but we do like to look at efficacy to make sure that we're maintaining treatment success and patients don't become resistant to the drug over time.
So I believe I was part of the study too, if I remember correctly. We used it as on needed basis, correct? Like a real life study.
Yeah, and that's important because, when you're using a medication, you kind of want to use it when you want to use it. And so it was really designed in a really nice way. So if I was breaking out on my face and I got my face all cleared up, but I still had spots on my legs, I was allowed to stop treating my face and just treat my legs. So, and I could treat my face not only till I'm clear, but I treated an extra few days just to make sure I was completely clear, and then I was allowed to stop. So it was really on and off, and I didn't have to go ask the doctor, can I go have my medicine back? I was in control of as the patient. The patient was in control of their own treatment.
And now that you brought up your face, so there is no limitation, right? Just like I'd like to confirm it, there is no limitation where you can use the drug like topical steroids.
Yeah, and that's, Leon, we all have, you and I have been practicing for a little while, and we all have those patients who come into our office. They have a bag of medicine. They've got some topical steroids. They have topical calcineurin inhibitors. They might have some PDE4s. They might have a little clobetasol, a little hydrocortisone, and they don't remember what's what. They knew that something was supposed to go on their face. They don't remember. Maybe it was that clobetasol. Something else goes on their body. Something else goes on the sensitive areas. People don't remember. And when they have a lot of medicines, I don't blame them. It's hard to remember. You walk out of the doctor's office, you already forgot what they said to you. So the idea that we can simplify the regimen, give them one treatment, whatever they want to do with it, wherever they want to use it, as long as they use it kind of up to 8 weeks and then on and off as needed chronically and not exceed the 20% body surface area, we set them up for success.
I think that's excellent. Let me check if we have any more questions. We answered most of them here. Is anyone studying Opzelura for other very itchy dermatoses, such as lichen planus?
So at this point, just generally speaking, often what happens is we get a drug and we look to see what it's effective for. And then generally what we do in clinical trials is we try to decrease the age to lower and lower, because that's important, because we know, especially for atopic dermatitis, patients can have this disease even in young children. So I think that for many pharmaceutical companies, before they explore other indications, they usually broaden out the age range for the existing indication. Whether or not there are other indications that will be explored for Opzelura, I don't know at this point, but it's the art of medicine. When we have a good drug, I'm sure we're going to find a lot of other diseases where that particular medication might be successful as well.
Perfect. That was our last question. I thank you so much, Linda, for being part of the International Dermatology Education Foundation series today. And our next meeting will be with Dr. Adam Friedman as our speaker, I believe on August 15th on the same topic. Thank you, Roxanne, for putting that up. So I thank you everyone very much for being part of our audience, and I wish you a great day.
Thank you. Bye, everybody.